Okay,
we
great.
continue with the next topic. And
Thank you. Thank you.
It's very controversial indeed. Shall we protect or shall we not protect the carotid stenting?
So I'm just checking whether Professor Matthias is here or not, because it's very difficult to talk about such an issue, such a challenging issue here. And okay, he's not here. I'm safe. So first of all, I would like to thank Ivo and the organizing committee for having me in front of such a distinguished audience. And I have some doubts regarding the protection devices. Let me share it with you. So it all began with the 2017 ECS guideline. It upgraded the use of protection devices during carotid intervention to a class 2A indication. The evidence, however, was C, which means evidence is still lacking. So let us go through the evidence the guideline has provided us, because we are cardiologists and the ECG guideline had such an upgrade of that, and we were a little bit disappointed, so to say. So if we go through the references here, under the headline of protection devices, we have the references from 101 to 110. And reference 101 mentions about embolic materials in the filter. If one comes up with such incentive to use protection devices, then another one can easily remind you of the harm of protection devices when you are the protection devices that can cause. So the references from 102 and 106, these are references that are irrelevant with the topic, because these references are studies that are comparing distal and proximal filters, proximal protection and the distal protection, and they are comparing them, and they have nothing to do with no protection at all. So reference 107 and 110, these are studies, secondary analysis indicating that protection devices should be used. But these are old studies, nothing new here. So, and the 110 reference is totally irrelevant again with the topic. And besides, the guideline admits the lack of high quality data in the last sentence of this guideline here. So this is the case. Just I want to go back, and here this is the case I have done without protection, and this is a very tortuous carotid anatomy with two gladius wires, and I was managing to go into the internal carotid artery. Here you have the amplatz stiff in place, then comes the sheetless catheter, and you will see we have here a tight lesion in the internal carotid artery. Here the wall stent in place, and post dilation, of course, without any protection device in place, and you will see the post dilation now. And here comes the end result. We did an MRI, of course, 24 hours after the procedure, and you will see there is no difference between pre and post procedure after this no protection procedure. So let me explain why I dare to do carotid intervention without protection devices. This is a pooled analysis, and it shows us, this is a pooled analysis of the EVA 3S and the SPACE trial, and shows no significant difference in the overall event rate. This is another study published in Journal of Vascular Surgery. Here, the technology of the filters are improving, but stroke rates are worsening according to this Archer study. We have two single randomized trials using new lesions on the diffusion MRI as endpoint surrogates, and this study indicates that CPT protection devices are useless or may even be counterproductive. So this is another case example, a very calcified internal carotid artery. The other carotid artery was totally occluded. So here the stents jumped upwards and leaving the lesion uncovered, and not a nice result, I know. The second stent could not be advanced because of heavy calcification. We had to post-dilate this lesion in order to cover the lesion completely, to put another stent there. And we had to balloon it, of course, without no protection. And here comes the second stent in place, and the final result on the left panel. The patient luckily was discharged without any adverse event. I can give an excuse, of course, why I did this without no protection, but this is not the topic here. So what we really need, for me, is a meta-analysis of these 5 randomized trials comparing protection without no protection. Until then, the class 2A indication seems a bit overrated for me, at least for me. Yeah. So we have evidence from 2 single-center studies again, with over 200 patients in each. And without any protection device, these studies showed us that it's feasible with very low ipsilateral stroke and death rates. The rates were 1.2 and 1.4%. Respectively. These rates were even better than the landmark randomized trials in which the periprocedural ipsilateral stroke death rates ranged between 4.5 to 9.6%. This is here another case. This is a string sign, as you see, near occlusion. I doubt whether any distal filter or any distal protection device would pass without predilation. If you predilate for filter passage, what's the point using a protection device then? Here again, predilation with the 3-point something balloon. And after standing, not even silent emboli in a diffusion MRI results after 24 hours. So here is the ISCC study provides interesting data to the current topic. For instance, the ischemic stroke mechanism during peri-procedural carotid intervention is 66% hemodynamic in nature, which means it is not preventable by any kind of protection device. So besides ischemic strokes due to catheter-related disruption of the plaque in the aortic vessel during intervention is not preventable by any kind of protection device either. So on the contrary, the protection device itself may cause stroke during the advancement, deployment, and retrieval maneuvers of the device. So with all this data at hand, this is again a secondary analysis of the ISCC study, and this result was not surprising to find out that the protection device usage was not one of the predictors of stroke as published here in this secondary in this manuscript. So here is another very tight internal carotid artery, another string sign, near occlusion. Here again, predilation without any protection. Even the balloon jumps forward, which seems scary. And here you can see the reason of the jump, very tight and calcific. Lesion only managed properly with high pressure post-dilation. The patient was again fine and discharged uneventfully without any diffusion MR emboli signs after the procedure, after 24 hours of the procedure. So in order to find a sound answer rather than relying on expert consensus, in 2016, we initiated the CASWEB trial after losing 3 centers at the beginning of the study, and due to the publication of the recent 2017 ESC guideline, it became impossible to reach the target sample size for us, but we did our best. Although randomized, it is underpowered. The primary endpoint was a combination of a procedural in-hospital transient ischemic attack, ipsilateral stroke, and death. For a randomized trial, we know that aiming at an embolic stroke, it would require several thousand patients to reach a meaningful endpoint during the evaluation of any kind of protection device safety study. So it was a bit difficult and tricky. And to increase the event rate, we different from all the landmark randomized trials, a transient ischemic attack was also incorporated to our primary outcome. And it was interesting that the only transient ischemic attacks were seen in the group which had protection devices, mainly, of course, distal protection devices. And we did every combination possible to find any difference in the clinical endpoints, such as ipsilateral stroke death, TIA, ipsilateral stroke plus death. None of these were different between our groups, and our final outcome was not able to find any difference between protected and unprotected carotid intervention. And here, in summary, here I would like to quote again the ACC statement, which says, given the lack of high quality data. For me, this statement means it is still too early to blame someone for doing procedures without protection, but I am very afraid of what Professor Matthias Klaus will say about that. I know it's a bit provocative, and this is at the first beginning I said this is going to be a provocative presentation, but that's what we all have at our hands, scientifically speaking. So 2A guideline upgrading, I don't know. So thank you for your attention.
Do you think it might be possible, Professor Landera, that we could hear your opinion, because you have been the investigator on many of the protection devices?
Yes. First, I think that really it's difficult to demonstrate difference between protected and unprotected procedures, because actually the incidence of distal embolization, but no distal embolization of a stroke, is around 1%. Then to have difference in 1%, you need 2,000, 3,000, 4,000 patients. I don't know. I am not a statistician. But in my opinion, it is necessary to select the patients. You have a patient with symptoms, frequent symptoms in the last month, you need protection. You have an asymptomatic patient with a calcified lesion without signs of risk in the Doppler, in the echo Doppler, you can not use protection. If you have difficulties in introduce the protection device with elongation of the distal carotid, atherosclerosis of the distal carotid, and so on, you can avoid distal protection. But then I think that it is difficult to have evidences about the benefits of distal protection. Then the clinical judgment may be the most important criteria to use or not to use. To resume, symptomatic patient need protection, asymptomatic patient probably not. Difficult patients don't need distal protection. Easy patients may be easy to use it.
Yeah, the problem is I went deep into the scientific literature, and the saga began with the EVA 3S trial. With EVA 3S trial, the first cases and a lot of stroke procedures, so they stopped the study. And stopped the study, and they began the study again with protection devices. And I don't know, it seems a bit scary, I know that, but I'm just trying to find real scientific evidence that we can rely on. That's now what I would like to talk. It's also my routine practice. I don't want to send the wrong message here, so I'm doing my cases with protection devices, okay? But what I wanted to say here, is there anyone beyond my literature knowledge, is there anyone who can help me with giving me sound scientific evidence regarding this?
So just maybe a brief comment. I remember that when space and EVA 3S was mentioned, that Jens Fieler, which you also quoted, he calculated the number of patients you would need to prove superiority of a filter device. It was like 56,000. Almost to prove superiority, not equally or non-inferiority, but superiority. So it was just a number nobody would invest. So probably there will be not really strong evidence whatsoever. But so we presented recently at the SILS Congress something from the road saver registry, which is a mesh-covered stent, so there is maybe protection device on it, and there was no difference of those being protected and unprotected additional to a mesh-covered stent. But this is preliminary data so far, but also interesting.
Quick comment on the EVA 3S study. In the EVA 3S study, out of 23 strokes, 21 of the strokes actually happened after the procedure, and dual antiplatelet therapy at the time was recommended. It was in order to keep the study going. So regarding protection, we published our first series many years ago when we started with carotid stenting, with 300 consecutive cases where that all were stented without protection, looking at DWI lesions before and after, and all the patients having transcranial Doppler during the procedure. And we found that we had the least amount of DWI lesions compared to any study that was published by then using distal protection device. However, when proximal protection systems came on the market, the whole situation changed. So when we're talking protection system, we cannot say, oh, everything is the same protection system, because not every protection system is suitable in the situation. Talking about the TIAs, I suppose that many of them were used using a proximal protection system, which you can also overcome. So you have to look a bit more critically. The question you are posing is very correct. Do we need to look at the lesion, and is that lesion prone to cause emboli in it? And the best way you can, and when we're talking about stents, we're usually talking about closed cell device, not closed cell. What about the delivery system? We found in our series that we had the least amount of DWI lesions in the most open cell design, but that is because we were not using protection and it had a very sleek delivery system. So main thing is characterization of the lesion, analysis of that, proximal protection, use of transcranial, look at the hits, what are happening, that will help modify the disease and adjust it to the situation of the patient.
Very quickly, since you mentioned the importance of characterization of the lesion, what technique of imaging are you using to do this?
You would use Doppler duplex, and in addition MR. You would look at interplaque hemorrhage. So also, I think the concept of the degree of stenosis as the indicator of which lesion is going to be symptomatic is completely outdated nowadays. We have every patient that comes with a symptomatic lesion, that lesion was asymptomatic the day before. So we have got to move away, and we have published with Piotr Musalik a concept which takes into consideration a whole range, we call it the roulette, of what are the odds for a lesion to become symptomatic, and it is not just stenosis.
Sure. What do you feel about GSM, grayscale median studies in circulation? Maybe we could talk after. I hope you've got your answer a little bit from a very controversial and lovely presentation. Thank you very much indeed.
Thank you.
And maybe we could do the last presentation just to end before dinner. Dr. Langhoff is going to discuss